E4, confluence is not forming, and E5 is there is a stricture involving the aberrant right sectoral duct and along with or without common hepatic duct stricture or common hepatic duct involvement. Okay, so this is regarding bile duct injuries. So the next topic that we are going to start is cholangiocarcinoma. What all are the risk factors for cholangiocarcinoma? The risk factors are choledochal cyst. Most common site of cholangiocarcinoma in choledochal cyst is intracystic cholangiocarcinoma or cholangiocarcinoma of the bile duct, most commonly from the posterior wall. Then the next is presence of CBD stones, primary sclerosing cholangitis, ulcerative colitis, cirrhosis, hepatitis B, hepatitis C also leads to cirrhosis, and other causes of cirrhosis can also lead to cholangiocarcinoma, mainly the intrahepatic type of cholangiocarcinoma. Then Clonorchis sinensis, Opisthochis viverrini, and asbestos, nitrosamines, dioxin, thorotrast, and isoniazid. Okay, so these are the risk factors for cholangiocarcinoma. Generally, this is the anatomy of the CBD. Cholangiocarcinoma can be of the proximal cholangiocarcinoma, mid CBD cholangiocarcinoma, or a distal cholangiocarcinoma. Okay, out of these three, proximal cholangiocarcinoma is the most common type. In cholangiocarcinoma, what happens is in the clinical presentation, most commonly the patient presents with, or the most common symptom is painless progressive jaundice. And this is followed by weight loss. Okay, so the most common is painless progressive jaundice. Okay, now some important points. So most commonly the cholangiocarcinoma is of hilar cholangiocarcinoma types. Hilar cholangiocarcinoma is also known as Klatskin tumor. There are some features of the cholangiocarcinoma, that it is of three types. The three types are diffuse infiltrative or sclerosing, then nodular or mass forming, and third type is papillary. Among these three types, papillary one is having the best prognosis. This is grossly, okay. So grossly, the papillary type is having the best prognosis, and the sclerosing or diffuse infiltrative is having the worst prognosis among the three. Okay. Then histologically, the most common type is adenocarcinoma, and the tumor markers are CEA and CA 19.9. Now, the patient generally presents with painless progressive jaundice, weight loss, anorexia, and pruritus, and sometimes clay colored stool. Okay, so this is the general presentation. As is can be easily understood with this diagram, if the patient is having a distal obstruction here, the gallbladder will be palpable. But in cases of proximal obstruction, gallbladder will be not palpable. Okay, there is a very famous law known as the Corvisious Law. Now, what is the Corvisious Law? Okay, the Corvisious Law states that in cases of obstructive jaundice, due to stone disease, gallbladder is seldom palpable, or is not palpable, or is rarely palpable. Okay, so if there is obstructive jaundice due to stone disease, gallbladder is rarely palpable. Okay, and in the other words, we can say that if there is obstructive jaundice due to malignancy, generally the gallbladder is palpable. No, this is not the case. The Corvisious Law states that in obstructive jaundice due to stone disease, gallbladder is rarely palpable. Okay, in cases of distal obstruction, ampullary tumors, or distal cholangiocarcinoma, CA head of pancreas, the gallbladder is generally palpable. If there is stenting done for biliary obstruction, the gallbladder is not distended, and because of relief of biliary obstruction, gallbladder is not palpable. In hilar cholangiocarcinomas also, gallbladder is not palpable because the obstruction is proximal to the insertion of sixth duct. Okay. Now, the next top point is why the gallbladder is not palpable in cases of obstructive jaundice due to stone disease. Because of chronic inflammation here, the gallbladder is shrunken and fibrosed. Okay, so gallbladder is shrunken and fibrosed due to this chronic inflammation. Now the next point is what all are the exceptions to Corvisious law. So the exceptions will be cases in which there is presence of obstructive jaundice due to stone disease, but the gallbladder is palpable. Okay. So the exceptions are: number 1, double impaction, in which there is one stone impacted at cystic duct and one in CBD. Second is presence of mucocele, in which the gallbladder is palpable. Third is presence of oriental cholangiohepatitis. Okay, because there are presence of multiple stones in the intrahepatic stones also known as hepatolithiasis. And next is stone impacted at ampulla of Vater. Okay. So exceptions to Corvisious law is when there is obstruction due to a stone disease, but the gallbladder is palpable. Okay. Now coming back to the cholangiocarcinomas, I've told you cholangiocarcinomas can be hilar cholangiocarcinomas, mid-CVD cholangiocarcinomas, or distal cholangiocarcinomas. Now there is another term, that is ampullary carcinomas or periampullary carcinomas. Okay. Now what is a periampullary carcinoma? Periampullary is surrounding the ampulla, and this is ampulla and 2 centimeter diameter around the ampulla. Okay, so this is within 2 centimeter of ampulla. And this includes carcinoma head of pancreas, distal cholangiocarcinomas, ampullary tumors, and duodenal carcinoma, which is present within 2 centimeter of the ampulla. Okay, so these 4 together forms the periampullary carcinoma. Why they are clubbed together? Because the treatment is same for them. The treatment is a Whipple's pancreaticoduodenectomy. Treatment is Whipple's pancreaticoduodenectomy. Okay. Now, but as the organ of origin is different, so they have a different prognosis. Okay. So the best prognosis among all of them is of duodenal cancers, and the worst prognosis is of carcinoma head of pancreas. Okay, so this is regarding the terminology periampullary cancer and the ampullary cancers. Okay, now in the cholangiocarcinomas, for proximal cholangiocarcinomas, we have a classification which is Bismuth correlate classification. To understand the Bismuth correlate classification, it is important to understand what is a primary biliary confluence and a secondary biliary confluence. Okay, so as in this diagram it is visible that there is a left hepatic duct and a right hepatic duct which is joining to form a common hepatic duct. Now this junction where the left and right hepatic duct is joining together is a primary biliary confluence, and in the liver, inside the liver, there are two different segmental ducts joining together to form a left hepatic duct. That confluence is known as a secondary biliary confluence. Okay, and suppose the right anterior and the right posterior duct is joining together to form a right hepatic duct, and that will be a secondary confluence for the right duct. Okay, and segment 2-3 duct joining together with the segment 4 duct, this will be a secondary biliary confluence for the left hepatic duct. Now, for these tumors, there is a Bismuth correlate classification. This is the diagram, and type 1 is tumor at the CHD, common hepatic duct. Okay, it does not involve the confluence. Type 2 is tumor involving the primary biliary confluence. Primary biliary confluence. Okay, and the secondary biliary confluence is not involved. Type 3A is tumor extending to right secondary biliary confluence, and type 3B is tumor extending to left secondary biliary confluence, and type 4 is tumor extending to both secondary biliary confluence. Okay, now if there is a tumor which is extending to both right and left secondary biliary confluence, this is unresectable tumor. Because to take a margin, we'll have to resect, and we'll have to anastomose all the separate bile ducts. So this is unresectable tumor, and resection is not advised. This type 2 is a classical Klatskin tumor, or tumor which is involving the hilar confluence. Okay. Now, what is the and is type 2 is the most common type. Among these all, type 2 is the most common type. Now, investigation of choice for the cholangiocarcinoma is MRI with MRCP. It is better than CCT because we get both a biliary cholangiogram also along with the other investigations which we get on other findings which we get on CT. We get a separate cholangiogram in along with that in MRI. That is why MRI with MRCP is the preferred investigation and is the investigation of choice for cholangiocarcinomas. Now, suppose this is a cholangiocarcinoma. This is MRI picture. This is MRCP of a patient with jaundice. What is the type of cholangiocarcinoma or a hilar cholangiocarcinoma? What is the type of hilar cholangiocarcinoma? The type of hilar cholangiocarcinoma. So it is simple. You can see here it involves the hilum. The CHD is normal, but it involves the hilum area as well as the right and the right anterior and the right posterior duct are separate. So it involves the secondary confluence of the right also. Okay. So this is for your reference. Now you can see here that it is involving the confluence primary as well as the secondary confluence of the right side. So it is a type 3A. Okay. Now this is what? This is a cholangiocarcinoma. This is a patient having jaundice and MRCP is showing dilated CBD as well as dilated pancreatic duct. So this is basically a double duct sign. Double duct sign is classically seen in ampullary cancers and is also seen in CA head of pancreas. Okay, so if you are having a dilated CBD as well as a dilated pancreatic duct, so this means that there is some obstruction at this side. There is some obstruction at this side, and the obstruction can be due to ampullary tumor or due to some carcinoma in the head of pancreas. Okay, so the treatment of choice for this patient is Whipple's pancreaticoduodenectomy. Okay, and double duct sign is classically seen in ampullary cancer, can also be seen in CA head of the pancreas. Okay, now for this cholangiocarcinomas, for hilar the treatment for hilar cholangiocarcinomas, the treatment is CBD resection with resection of the tumor with a routine caudate lobectomy with removal of lymph nodes. Okay. Why a routine caudate lobectomy in all hilar tumors? Because the caudate is early to involve because it receives the blood supply from both left as well as right lobe, and it is very early involved in the hilar cholangiocarcinoma